Greetings, NACCHO360. We're so grateful to be here and share this upcoming conversation with you all. Thank you to NACCHO for holding space for this dialogue. My name is Amir Sadeghi. I use he, him pronouns. I'm the Policy and Advocacy Manager with the Center for HIV Law and Policy. This session is called What We Do Now, Data Privacy and Public Health in the Authoritarian Police State. We're going to wrestle with this topic today because surveillance, policing, and the weaponization of data represent some of the gravest threats to public health, fundamental rights, and the human dignity of marginalized people in the United States. I believe these threats rival the devastation of sweeping cuts and mass workforce dismissals impacting all of you. The legacy of lane crossing between policing and public health has undermined our ability to even be able to achieve the goal to protect our people and our health. To confront these challenges, public health officials need grounded assessments on the legal frameworks governing health data and the practical solutions to better protect marginalized communities. This panel will unpack the evolving legal and policy landscape in our current political context and draw from the HIV anti-criminalization movement to offer a broad cross-sector analysis of public health legislative and policy interventions. A little bit about who we are at CHLP. CHLP is an abolitionist legal and policy organization that envisions a world where HIV and other stigmatized health conditions are no longer criminalized, but met with compassion and the resources to thrive. We center our work in communities of people living with and deeply affected by HIV and other stigmatized health conditions. CHLP utilizes legal advocacy, high-impact policy and research initiatives, and the creation of multi-issue partnerships, networks, and resources to support our communities in this work. You can find more information at our website here on your screen. And I also wanted to just make a quick note about the consensus statement on HIV bodily autonomy, surveillance, and informed consent, or BASIC, here on your screen. HIV BASIC and this expert consensus statement was launched by Michael Scarce, an activist and writer living with HIV, CHLP, the Positive Women's Network USA, the Zero Project, HIV Justice Network, and Transgender Law Center. It celebrates the principles and analysis we need to better center the equity, dignity, and human rights of people living with and deeply affected by HIV as we look to rebuild our public health infrastructure in the wake of authoritarian and senseless attacks, funding cuts, and growing mistrust in health systems. At the time of this taping, we are nearing 200 organizations who've endorsed this statement, including NASDAD, the Association of Nurses in AIDS Care, the Center for Health Law and Policy Innovation, GLAMA, Health Professionals Advancing LGBTQ+ Equality, the Southern AIDS Coalition, NMAC, the US People Living with HIV Caucus, and so many more, as well as over 200 individuals. Please visit this consensus statement with this QR code and use it in your advocacy to protect our communities and center people living with HIV in policymaking. I have the distinct pleasure of moderating this incredible panel of experts to unpack health data privacy, authoritarianism, public health education and organizing, and ways we can protect our communities from criminalization, rising inequality, and invasive mass surveillance. We are joined today by Kenyon Farrow, the writer, editor, and strategist whose work has long focused on public health, housing and homelessness, and the social safety net with a focus on racial, gender, and economic justice. Christine Mitchell is the program director of Health Instead of Punishment program at Health in Partnership, a national public health nonprofit headquartered in Berkeley, California. Ali Bohm is a senior policy counsel at the New York Civil Liberties Union. She develops and advocates for policy solutions primarily related to gender and sexuality, in particular LGBTQ equality and reproductive freedom, and privacy and technology. And finally, Sarah Gagan is the Consumer Privacy Project Director and Senior Counsel at the Electronic Privacy Information Center. She focuses on commercial surveillance, consumer privacy, and health and reproductive privacy. So I'm really excited to kick off this conversation with you, Kenyon. Um, I think actually a lot of NACCHO members attending and engaging with this workshop might not know that 32 states have an HIV-specific criminal law, and that general crimes, including aggravated assault and even attempted murder, have been used to target and punish people living with HIV. So what are some of the trends from your experience working in public health in the realm of HIV criminal legal enforcement that you think NACCHO members really need to better understand to kind of confront this rise of state violence that really continues to affect communities of people living with HIV?
Thank you so much, Amir. I'm very glad to be in discussion with you and the other panelists. First, I would, offer that as we think about HIV criminalization, number one, the criminalizing of HIV status, or in the way some of the laws are written around, exposure or potentially just not disclosing that one is living with HIV is actually not entirely new. If you look at the history of public health in the United States, one of the things that we've seen pretty consistently is infectious disease outbreaks kind of being blamed on various sort of marginalized groups, and often people from those groups also being criminalized. I often remind people of, people have heard the term Typhoid Mary, right? And this particular person was an Irish immigrant, in the early part of the 20th century, living in New York, who had typhoid. And she ended up becoming very much the sort of face of this infectious disease. And of course, at the time, it was considered, the Irish were, dirty. They were poor. They were unkempt, and these other things. And so, this has been baked into kind of how we address infectious diseases. But if we fast forward, to HIV, one, I think that the early, beginning of us understanding that HIV was impacting people in the United States, we often start with 1981 and the CDC MMWR that, outlined a rare cancer in, I think, 7 gay men in a couple cities in the United States. And pretty shortly thereafter, the sort of first way HIV was described in terms of a condition was gay-related immune deficiency, or GRID, right? Which I always think about, like, how is an infectious disease, or at that point they're looking at the kind of symptoms that were happening to people as they were dying, gay-related? Like, what does that even mean, right? But that tells you something about the social, cultural, political issues at the time. We're into the first couple of years of Ronald Reagan as a president, and we were living through a conservative backlash to the gains of the LGBT movement, of Black civil rights movement, the feminist movement, et cetera. And so it actually makes sense in a weird way that HIV would be framed first as a gay-related condition, because those are the bodies that it was recognized in first. But it wasn't too short thereafter where it also begins to be racialized. So in 1982, the first law banning Haitians from entering the United States as a threat happens. And so, we start to see then the way Haitians are talked about in terms of HIV. So it becomes both a kind of condition that is kind of placed upon the bodies of gay men of all races, and then on Haitians more writ large. So that it starts where we are. And then what we begin to see in the 1980s is states begin to pass laws that criminalize, HIV, whether we're talking non-disclosure, exposure to HIV, or transmission of HIV. And then certainly by 1990, we, look at the start of the Ryan White Care Act, which was, obviously the act that created health services for people living with HIV. But what was embedded in that, the first iteration of the Ryan White Care Act, was a provision that states had to have laws in place to prosecute people who intentionally spread HIV. And, you know, a lot of times people think that Ryan White Care Act is what started HIV criminalization. No, it actually just codified it in some ways at the federal level when states had already been passing laws or using laws on the books to target individuals for supposed non-disclosure or exposure or transmission of HIV. And so that's the basis of where we are today. And, you know, I'm very glad that in the last, several years, roughly 10 years, we've seen a lot of community organizing and advocacy at the state levels that have helped, kind of reform some of these laws in certain places. But we also have been seeing in the last couple of years in the Trump era, people calling for even stricter laws in certain states, right? So we're now in a place where some of the laws that were reformed, there's blowback, or politicians are using, people living with HIV as a way to score political points. And so, we still have more work to do.
Yeah, well, thank you so much, Kenyon. And, I'm really glad that you touched on the ways in which race and identity became, these disease categories, right? Through really harmful and even stigmatizing guidance from public health officials. We remember the 4-H kind of framework that the CDC was using at the time. Are you concerned, or have you seen this element of identity-based criminalization being a part of this authoritarian shift that we're experiencing? I know you alluded to, some of these changes in the Trump era. What are you seeing on the ground right now? Who's being really affected? And what do I think we really need to better understand in this current political moment on how identity, race, and disease kind of collide in these ways where the state takes advantage and even weaponizes those elements about our identity against us?
Yes, I think that what's happening is that HIV is being used to, essentially sort of prop up various kinds of criminalization and targeting of specific groups. So it's in one way a way to push back against a lot of just the general work that a lot of folks have been doing, actually from the left and the right over the last roughly 10 or 15 years, to actually decarcerate and stop relying on, mass incarceration, right, as in the United States. And again, there have been calls, within, folks, again, on the left and the right to sort of reform just how we criminalize people and put, everybody or range of issues, put people in prison to the extent that we have over 2 million people in prison in the United States, the biggest incarcerator in the world. So some of it is because people have a vested interest in upholding just the carceral state, as people suggest. And so if you continue to figure out ways to scare people into thinking that we still need to throw people in prison, you prop up this entire economic infrastructure, right? Which has impacts certainly for, poor people, for Black and brown folks who are disproportionately impacted by prison and jail sentences. But it also becomes a way to also, kind of fuel the culture wars through which HIV gets connected to people who use drugs. It gets connected in the drug war. It gets connected to Black people, I would just say, more writ large. And it certainly gets attached to sex workers, to gay men, to trans women specifically, right? So it becomes a way through which basically right-wing forces can both continue to basically advocate for why we need, mass incarceration in the United States and strong sentences and being tough on crime and all this stuff that we're hearing about, law and order is right. We're not really saying tough on crime anymore, but in the Trump era, it's been like law and order has been the frame. So it's doing that work, but then it's also doing the work of continuing to stigmatize people, marginalized people, as a way of again propping up that system, but also beginning to scapegoat individuals or communities of people to further create situations where they are more disproportionately put in prison for a range of reasons, and HIV criminalization being one of those. Right, it's still in a lot of ways, despite the fact that there are other infectious diseases that we've dealt with in terms of outbreaks in this country, but HIV still is the sort of boogeyman for a lot of people, and it is the sort of trigger that then a lot of right-wing forces think that they can use in order to manipulate people into buying into continuing to enforce draconian laws in our case that target people living with HIV.
Thank you so much, Kenyon. I actually think this would be a really wonderful point to transition to you, Christine. I'm really excited that we're having this conversation about criminalization and public health. And, I'm wondering if you could tell us a little bit about Health in Partnership's Health Instead of Punishment initiative.
Yeah, totally. So like you said in introducing me, I'm the program director of our Health Instead of Punishment program. Health in Partnership is a national public health nonprofit. We're based in Oakland, California. And we have many different kind of parts to our work and many different issues we work on. But our Health Instead of Punishment program focuses on the health impacts of policing, criminalization, surveillance, immigration enforcement, incarceration, kind of that whole bucket of things. And what we try to do is build capacity within the field of public health in kind of partnership and following the leadership of folks who are directly impacted by the criminal legal system and the immigration enforcement system to win policy and budget campaigns that really re-envision how we create safety, how we achieve justice and accountability, how we foster health without relying on policing and punishment. And so our vision is to work towards a society where people have what they need to thrive, where people are healthy and free, and where our collective resources support care rather than punishment and harm. And ultimately what we're working towards is a world where, because we have built up those community-based systems that keep us safe and accountable and healthy, there's no longer a need for things like policing in jails and prisons, detention centers, surveillance, kind of any parts of the prison industrial complex. Our program's been explicitly abolitionist since 2019. Prior to that, we're mostly working kind of on abolitionist campaigns, but without kind of applying that word to the work. But yeah, there are several different parts to our work. We do policy-driven research in partnership with community orgs that are working on abolitionist policy and budget campaigns or program development. We do advocacy and organizing work, again in partnership with community power building organizations, and we do capacity building work. So we run a network for public health students and faculty who are interested in learning more about abolition and organizing abolitionist campaigns on their campuses.
Well, that's really wonderful. And I think it would be great to hear about some of these particular examples. I know HIP has done some great work partnering with public health associations and organizations before to really drive home that point. I know you're talking about community power building to address the way that health systems, public health infrastructures can kind of facilitate criminalization. So I'm wondering if you could speak a little bit about the non-collaboration pledge that Health in Partnership worked to bring forward.
Sure. Yeah. So, like you said, HIP works kind of across sectors within public health. So we work with governmental public health and public health departments. We work with NACCHO. with the American Public Health Association to really build capacity and develop understandings of health equity and racial justice and the importance of community power building. We work with folks in academia and public health. We work with community health workers, community power building organizations, with researchers. So we work very broadly kind of across the public health field. One thing that HIP supported with was the American Public Health Association has passed 2 policy statements, one in 2018 on police violence as a public health issue, and one in 2021 on carceral systems, which explicitly names abolition as a public health goal. And so the collective that co-authored those statements, we call the End Police Violence Collective. That's separate from HIP. I'm a part of both. And in 2020, during the uprisings for Black liberation after the police murder of George Floyd, the End Police Violence Collective wrote this pledge of non-collaboration that you mentioned. And what that was and is a statement that we had public health folks sign on to, clearly stating that the goals and the impacts of policing and public health are completely antithetical, that policing harms health, and that partnership with law enforcement also only serves to harm health rather than protect it. And that's a challenge that we face a lot in public health because public health has its own problems and interconnections with criminalization. It's often been used as a tool of the state. We saw that a little bit with COVID and kind of historically through the ways that policing and public health intertwine during epidemics and kind of forced vaccinations and things like that. And it's a challenge, I think, especially within the research sector in public health, because often police and departments of correction are, if not the only source of data, kind of the primary source of data. And then in government, in governmental public health, police are kind of seen as partners at the same decision-making tables. So what we really wanted to do with the pledge was encourage people to find creative ways to work around those systems rather than with them. And so we encourage folks to build direct relationships and partnerships with, currently incarcerated people, formerly incarcerated people, the people most disproportionately targeted by policing. And over 400 folks signed that pledge. And that's something I think that we try to carry on through HIP's work. We don't work with police or departments of correction intentionally. And it's something that we're kind of trying to disentangle from public health more and more.
Well, I think that's really wonderful. And as you said, Christine, there are so many examples we can point to, with the COVID-19 pandemic, when police were called on to enforce like social distancing summonses, right? And I remember in my city, those summonses went, 90% or roughly thereabouts of those types of criminal summonses for social distancing violations went to Black and brown people in my city. And I actually remember an interesting example connecting a little bit with HIV criminalization, the conversation that we had with Kenyon a moment ago, when 50 sheriffs were deputized as contact tracers during the COVID-19 pandemic in my state. And advocates, including a lot of public health advocates, wanted to get together to, really help sever the connective tissue between the criminal legal system and public health, the importance of building trust with something like contact tracing as a public health tool. Advocates explicitly didn't use New York's HIV confidentiality law, as a model here, because our HIV confidentiality law in New York has so many exceptions that permit the release of health information to law enforcement. And I know that's something Allie's going to talk about in a little bit, but I'm wondering, you mentioned, to kind of close us off, Christine, you mentioned that this pledge and really all of HIP's work grounded in an abolitionist politic, this emphasis on abolition as a public health goal and as a strategy. I'm wondering if you could explain to attendees here at NACCHO360 why that's so important. Why does health in partnership view abolition so critically as a public health strategy and goal?
Yeah, thank you. That's a great question. I think the crux of kind of why we think about abolition as a public health strategy comes from something that Ruth Wilson Gilmore, who's an abolitionist scholar and organizer, says, which is abolition isn't about absence, it's about presence. It's about building life-affirming institutions. And so we feel very clear that abolition is not just about no more prisons and police and immigration detention. It is about that, but it's also about building a world where people have what they need to thrive. So it's about building a world where people have things like housing and education and healthcare and food access and clean water and all the things that people need to survive, which in public health we often refer to as the social determinants of health, the social drivers of health, the structural determinants of health. So there's this built-in framework within public health to already understand kind of what we mean by building up and investing in the things that communities need. And public health often focuses on, what we call primary prevention. So intervening before disease or injury occurs, intervening before harm occurs. We call that sometimes intervening upstream. And that really is what abolition is about. And so we see this complete kind of parallel between what an abolitionist vision is and what a public health vision is. And many abolitionist organizers are already using a public health framework to talk about the world they want to see. I think, one thing that feels really important to name in this context to NACCHO is that in public health, we have a really particular story and a particular angle that we can tell about the health impacts of state violence, whether that's something that's perpetrated by ICE or by police or by DHS, any kind of arm of policing. The impact of the chronic stress and trauma on the body and on our communities is really immeasurable. And I know even, within the last few months, health workers are really activated and reporting kind of the devastating impacts of patients being detained by ICE in healthcare settings or not seeking life-saving or urgent medical care out of fear of being detained or deported. We know that conditions in detention centers are horrific. And that crosses, right? It's not just in detention centers. It's also happening in every jail and prison in the country. And so at HIP, a resource that might be helpful for NACCHO attendees, we created an immigration justice action guide. So that offers 10 different actions that people in public health agencies, specifically governmental public health departments, can take to mitigate the harms of immigration enforcement and support collective safety. So those are things like rejecting 287G agreements that allow ICE and law enforcement to kind of interact and support each other, preventing ICE and law enforcement surveillance and enforcement in healthcare settings. And we provide examples of health departments that are actually taking these actions already. So hopefully some inspiration that folks can draw from that. And I guess the last point that I really want to emphasize is that public health has a part to play in building this abolitionist world and resisting the world that we see right now. Our ultimate goal is abolition, and there are small and tangible steps that each of us in public health across sector can take towards that goal.
Now, speaking of health and public health and the roles that these systems play in some really harmful outcomes in the lives of our communities, this would be a really important juncture for us to start talking about health data privacy. So, Sarah, I know it's been a few months, but I just want to congratulate you again on the release of EPIC's new report, Beyond HIPAA. Huge deal and huge congratulations from us at CHLP. I think a lot of people engaging with this workshop are really curious about the extent to which federal law does or does not protect sensitive health information, learning more about HIPAA and really having a bigger conversation about privacy beyond just HIPAA. So can you walk us through these different issues like commercial surveillance and why weak data safeguards are an issue that you're tracking?
Definitely. Thanks, Amir, for these questions and for having me. I'm definitely happy to talk about these issues and our report. As Amir mentioned, it came out a few months ago, but I'll walk through some of the overall takeaways of the report. And I think there will be a link provided to anyone listening if you would like to check it out. But yes, we face a health data privacy crisis in the United States. It's caused by unregulated digital technologies, weak or non-existent privacy laws, or weak enforcement of existing privacy laws, the criminalization of many forms of healthcare, and growing federal attacks on marginalized communities. This lack of privacy protections leads to worse health outcomes and health inequities, and the solution is baking privacy protections into our legal and technological landscapes, because this privacy protections builds trust in healthcare. So our report talks about data brokers, ad tech surveillance, and ICE enforcement as some of the factors that are leading to this health data privacy crisis that's eroding trust and deterring people from seeking care. And our report really does highlight the role that tech companies have in orchestrating this health data privacy crisis. And one of the reasons that the data privacy crisis exists is because we do not have a general comprehensive federal privacy law that protects all of our personal information online. We do have HIPAA, which is the Health Insurance Portability and Accountability Act. And I think HIPAA might be the most misunderstood privacy law because people feel that it applies to anything that's sort of related to their health. But HIPAA has some limitations, largely in its scope. HIPAA really only applies to the traditional provider-patient relationship, and so much of the information that is constantly generated about us online, through our search history, through our location information that is tracked on our devices, through other information collected about our devices themselves, just are not health information protected by HIPAA, even when that information can be quite revealing. Your location information can show if you were at a clinic or a health facility, but that's not considered protected health information under HIPAA. So HIPAA has, just some limitations on what it can protect. And what the point of HIPAA is really about insurance portability and being able to move electronic records more easily. So it was never meant to protect, biometric information collected by your device or your WebMD searches that might reveal your health characteristics. So our report talks about the gaps here and how all of this information that exists outside of HIPAA can reveal our health characteristics, much to our detriment and in a very harmful way to consumers. First, the report talks about this data privacy crisis due to unregulated digital technologies and lagging laws and the misunderstanding of HIPAA. And then it also talks about the lack of privacy protections for health information leading directly to health inequities because people's health outcomes are worsened when they don't trust providers or when they're not able to access care due to stigmatization or fear. This makes it more difficult to obtain quality care. And there's many reasons why people wouldn't feel comfortable giving their information to a provider. And this mistrust or fear causes people to have delayed treatment or sometimes no treatment at all. And this worsens health inequities. Commercial surveillance plays a very large role in this data privacy crisis. Commercial surveillance is a system in which consumers are ubiquitously tracked and profiled online. And these consumer profiles that are built from our data are based in part by our health-related information. Profiling in this way makes healthcare more difficult and more expensive to access through practices like targeted advertising, surveillance pricing, and sales by data brokers to insurance providers. So health insurance companies and many other types of insurance, long-term care or life insurance, can buy information from data brokers and use it to profile or to profile potential customers to make coverage more expensive and to deny claims or to deny coverage. Targeted advertising is also a nefarious practice when it comes to our health information, because people may see advertisements for medicine or other types of care that is more expensive or less effective for their needs based on their profile. So pharmaceutical companies or other companies are able to use our data profiles, including information that reveals our health characteristics, to target ads for us. And this is exploitative and extracting our information because we are much more likely to pay for something when it kind of pulls at our heartstrings of like being related to our health and improving our health and our quality of life. Surveillance pricing is another harmful practice that uses our personal information to set an individualized price for one person that differs from the person next to them. And this can be very harmful when we're talking about healthcare or health, anything related to health, because someone is going to pay more money for something when they need it based on their profile. And surveillance pricing allows companies to use our information against us to try to infer the highest amount we would be willing to pay for something. And this is especially nefarious when we're talking about something as essential as medicine. AI, artificial intelligence, turbocharges many of the privacy harms that exist in commercial surveillance due to the lack of regulations for AI tools used in health contexts. This can include things like apps, chatbots, and websites that many consumers do use to consult for medical advice. Chatbots are not medical professionals. They are not qualified to give medical advice, but many consumers do interact with them in this way, and largely because a lot of more traditional healthcare is inaccessible or hard to access for many people and can be very expensive. So people do turn to unregulated technology in order to seek care. And these tools and these emerging technologies do not have the same safeguards and privacy practices or privacy regulations that other more traditional types of providers would. And they don't have the same oversight even for efficacy, accuracy, bias, discrimination, or privacy. So turning to these unregulated technologies can be very harmful, and it does open up a lot of our personal information, especially health-related consumer information, to a world with very little oversight or protections for it. And lastly, there are specific considerations when we're talking about children's health, because online practices like targeted advertising, addictive feeds, and engagement maximizing platforms do have an outsized impact on minors' health and well-being due to their vulnerabilities to certain technologies. So the report talks specifically about the unique concerns that children online have for their mental health and well-being, and offers specific protections, heightened protections for children online. But the health data privacy crisis has been severely worsened in recent years. Data brokers, ad tech, ubiquitous surveillance, and ICE enforcement are among the factors leading to this health privacy crisis. We've seen ICE's presence in hospitals, even standing behind the check-in desk. And this type of surveillance does deter people from care, whether it's physical in-person surveillance or it's digital surveillance online. It causes fear and it erodes trust, and it does deter people from seeking care. So yes, our report does talk about all of these things and how many different levels of surveillance and aspects of surveillance more acutely harms vulnerable communities, and this worsens health equity. So people retreat from care due to these privacy violations, and the report offers that protecting health data promotes health equity.
Wow. Yeah. And Sarah, thank you. And, just like you mentioned, we'll have this report attached here for attendees at NACCHO360 so they can access it. And I'm really grateful for that. And I think a lot of NACCHO members and attendees are probably really aware that we're really looking out on a cliff here where, these devastating Medicaid cuts are going to be implemented. And just like in the world of work that I do around HIV justice, close to half of people living with HIV who only are able to access treatment through Medicaid, right? So you kind of have this really troubling perfect storm of commercial surveillance, weakening data privacy, like leading to more mistrust, feeding into inequity, right when our health infrastructure and Medicaid and social safety net is really under attack. And I think, I think that's probably a really good transition point, actually, to talk about what we can do. What are the practical tools and strategies for action, for state legislation and policy, for clinics and health departments? And I would love actually to turn it to you, Ali. I know you do a lot of this work with the New York Civil Liberties Union. And I think we're at this really critical moment, as I was talking about, where folks need that practical guidance. They need the strategies and tools to protect their communities, to implement those safeguards. I know many argue that the Dobbs decision plunged the country into this world that we're living now and experiencing where, and we're in kind of doing damage control, trying to plug a leaky ship, and try to address the ways in which health information can be accessed and used against people in really harmful ways, and surveillance really affecting folks. So, Ali, what are legislative and policy solutions that you think NACCHO attendees really need to know about? What are you working on at the New York Civil Liberties Union to kind of advance more privacy and protections for our people?
Sure. Thanks for that question, Amir, and thanks for having me. And wonderful to see you virtually, NACCHO attendees. So, Amir, I think you're right that Dobbs was a moment in time. But as Kenyon so eloquently said at the beginning, that wasn't where this started. And I think even within the four corners of reproductive health, it's important to name that our friends at Pregnancy Justice have documented more than 1,800 cases where people were prosecuted for their behaviors during pregnancy or their pregnancy outcomes in the United States between 1973, so after Roe, and the Dobbs decision in 2022. So this is by no means a new phenomenon, unfortunately, but you are right. And let me step back for a second. And there have been folks in the repro movement, in many access to healthcare spaces, who have been fighting for more control over our health information and to prevent health information from being used to feed criminalization for a very long time. But you are right that Dobbs brought bodily autonomy into the fore in a way that it had not been for a long time before, both in terms of those of us who are fighting to preserve bodily autonomy, and also, unfortunately, in terms of the politicians who are trying to undermine it. We entered a world where something that is healthcare in New York and in many of our sister states is suddenly criminal in large swaths of the country. So you asked me to talk about legislative and policy solutions here, and you took my line. Often when we are talking about privacy and about protecting bodily autonomy in today's world, we are talking about patching holes in a leaky ship. So I want to start with what I think is the strongest model, and then sort of, I'm going to say move down from there, but it's move in some other directions, some more harm mitigation directions from there. So at the height of the pandemic, both for contact tracing and for access to vaccine and the use of immunity passports, so documentation that you had received a vaccine in order to participate in society, right? To attend a concert, to go to a restaurant, to do many of the trappings of modern society, participating in the public way. All of those things, we recognized that people simply would not participate if they were afraid that their information, whether that was information they shared with contact tracers, whether that was personal information they shared in order to receive a vaccine, or whether that was personal information contained in one of these immunity passports, people weren't going to share that if they thought that their participation might be used to criminalize them or deport them or take their children away, expose them to the family regulation system, which we could spend an entire other hour on, but is really the twin pillar of the criminal legal system, and unfortunately often disrupts Black and Brown families and all families, but particularly disproportionately Black and Brown families, for behaviors that often have more to do with poverty than with mistreatment. In any case, so for contact tracing and vaccine confidentiality, we passed legislation that prohibited law enforcement access and that made clear that that information, that the personal information shared to receive a vaccine or for contact tracing purposes or to use an immunity passport, could not be used to criminalize anybody or deport anybody, or in the case of vaccine information and immunity passports, to take their children away. I want to note that when we first started drafting that legislation, we looked at New York's HIV confidentiality law. And what we found was that that law had so many exceptions to it that it actually wasn't a good model. So instead, we modeled it on the federal census protections, which feels wild to say in the age of Trump. But those protections start from an underlying value that it is so important that people participate in the census that we are not going to use census information to criminalize or deport anybody. And so we started with that as a model and brought it into the public health space. In some ways, that is where a lot of our values are to begin with. Your health information just should never be used to criminalize or deport you or take your kids away. And your seeking healthcare should never be used for those purposes. But that's not always where lawmakers are, or frankly, sometimes where the public at large is. So we have a few other tools that we have been trying. I think the one that has received the most attention, for better or for worse, are shield laws. Again, they're sort of serving the same principle that providing or accessing or helping another person to access healthcare should not lead to criminalization or other adverse consequences. But we're talking about a more limited universe here. So we're talking about healthcare that is healthcare here in New York and in our similar states, in our sister states, but that is criminalized in other states. So namely reproductive health care and gender affirming care. The other challenge in this space is that it's not New York or any of the other access states that are the ones who are doing the criminalizing or the penalizing, and we can't control for the behavior of other states. But we passed a series of shield laws here in New York, and several other states have done the same, to make sure that the machinery of our state will not be used to investigate, criminalize, penalize, or assist another state to investigate, criminalize, or penalize someone for providing, receiving, or helping another person to access reproductive health care or gender affirming care. Those protections sound in the licensure and malpractice sphere. So we're not going to take away providers' licenses. We are not going to allow malpractice insurers to drop them or charge them unfavorable rates, et cetera, discriminating in their coverage. They also sound in the criminal legal system. So we have protections against domesticating subpoenas. For a long time, I talked about that as New Yorkizing subpoenas. A subpoena is a request for information or testimony that is only legally binding if it was issued in another state. It's only legally binding here if it is sort of reissued or New Yorkized. Domesticated is the legal term here in New York. Otherwise, it is a piece of paper. And so we have prohibitions on domesticating those requests when they have to do with what we call legally protected health activity, but essentially reproductive health care or gender affirming care. We have prohibitions on arresting and extraditing. Extraditing means taking someone from New York and sending them to another state to stand criminal charges. People for engaging in, again, legally protected health activity, providing, receiving, helping another person to access reproductive health care or gender affirming care, unless they were present in the state that is asking for them at the time that the conduct occurred and fled from that state. And the reason that that's a limitation is that that is a federal constitutional limitation, so we can't overcome it. And we have prohibitions on New York state resources and local resources supporting another state's activities to penalize, criminalize, or investigate someone for providing, receiving, or helping another person to access reproductive health care or gender affirming care. Again, as Amir said, and I've reiterated, but we are patching holes in a leaky ship, and there are so many ways for a hostile state that wants to penalize somebody for their access to reproductive health care or gender affirming care to get access to information without involving New York actors, without triggering our shield laws. So I want to share a few other approaches that we are actively working on at the time of recording. I hope at the time you're viewing this, we can say that we have some legislation that has passed both chambers, but TBD. We'll figure out if there's a way to update y'all. Anyway, so I want to share a few of the cutting edge things we are working on. So first of all, I want to, by way of background, sort of add a coda to what Sarah was saying about HIPAA. HIPAA, the P in HIPAA is portability, it's not privacy. And so even within the four corners where it does apply of the healthcare settings, it has so many exceptions that allow for law enforcement access to information. In fact, the number one way that someone who is criminalized for their behaviors during pregnancy or for a pregnancy outcome comes to law enforcement's attention is because a healthcare provider reports them. So one of the measures we are working on is electronic health record segmentation. That is a name only a lawyer could love, but electronic health records are on-off propositions. They serve important continuity of care benefits. The idea is that every provider who sees you has access to your full medical history so that they can avoid drug interactions, know your allergies, etc. The downside of that is that they're either on or off. So if you want those benefits, your entire record is shared and you can't control what information is and is not shared within it. And it is shared with every provider with access to the system. That includes the emergency department if you're traveling in Texas, my favorite banned state to pick on. It also includes your anti-abortion podiatrist here in New York or your anti-trans dentist. As you can imagine, that can expose people to discrimination, to criminalization, and to other adverse outcomes. So what we are proposing is electronic health record segmentation. This is already law in Maryland and in California and is being implemented, so it is doable. But essentially, it would require the electronic health record vendors to create the ability to segment an electronic health record and suppress sensitive information at a patient's direction so that a patient can have those continuity of care benefits without having the ER in Texas learn about their abortion or their anti-trans dentist figure out that they're trans based on their medical history. The second bill I will name is one that is a glimmer in my eye. It hasn't yet been introduced, but we are working on it, and a few other states have moved it forward. And that is a bill to remove testosterone from our state prescription monitoring programs. So prescription monitoring programs exist ostensibly as a response to the opioid epidemic. The idea is to avoid folks pill shopping. The reality is that it funnels a lot of people into the criminal legal system. But because testosterone, which is often used to support transgender men, is a controlled substance, all testosterone prescriptions are included in a prescription monitoring program. As a side note, this absolutely impacts cis people as well, because there are many, many conditions that folks take testosterone for. We know that Ken Paxton in Texas has used that state's prescription monitoring program to try to identify who might be trans and who might be providing care for them. We also know that New York's prescription monitoring program, much like most prescription monitoring programs in the state, in the country, and I believe virtually every state has one, share their data across state lines. There's no reason testosterone should be in there. And so that's a piece that we are looking to do. We're also looking to make sure that other medications, either used in gender affirming care or reproductive health care, can never be scheduled and included in the prescription monitoring program. We'll also hang a flag that there's more to do there, including requiring legal process before there is access to prescription monitoring program data, so that there is a neutral arbiter who has signed off and said, there's good reason to believe that this information is going to turn up evidence of a crime before law enforcement gets access to it. And then the last one I'll name is really right on point with what Sarah was sharing with us, which is health data privacy in the commercial space. So things like Fitbits, smartwatches, period tracking apps, changes in purchasing history that reveal health information. For example, Target has been figuring out when people are pregnant based on changes in their purchasing patterns. Spoiler alert, it's a lot of unscented lotion, since about 2012. Location information when it reveals health status. All of that information, as Sarah said, reveals health information, is deeply personal and receives no privacy protections at all. So we have in New York, the New York Health Information Privacy Act, New York Health Information Privacy Act, I think I said that, which would put in place some sensible privacy protections, give us some more control over those data, and importantly, set a presumption that those data would be deleted unless we ask for them to be retained longer. And there's good reason for that. If someone were, God forbid, in a situation where they are seeking time-sensitive care that might be criminalized, they might not be in a space to remember to ask Google or ask the Lyft driver who took them to the abortion clinic to delete those data. So creating that presumption is a really important safety measure as well. So I'm happy to talk about more of these as we come together for more conversation, but I recognize that I've been going on for a bit now.
No, Ali, I really appreciate this. And, I think weird policy wonks like me get excited hearing you talk about this. So I knew you were the right person to talk to about, what are these cutting edge ideas and strategies people are using right now. So I really appreciate that. And yeah, I'd love to bring everybody in for a bit of a discussion. I think the first thing that I really am struck by is how much trust was central to so much of what we've all been talking about, right? People are not willing to participate or engage in preventative or diagnostic care because they're afraid of these collateral legal consequences to engaging with it, right? And that the lack of health data privacy perpetuates that mistrust. I think it was really interesting, Ali, for you to talk about this research showing that care providers are really quite largely responsible for reporting cases of self-managed abortion to the police, where I know in the realm of HIV advocacy, this has also been an experience that so many people live through. I was actually just on a community advisory call yesterday where when a mother was pregnant with her child living with HIV, was basically told by her provider that she was going to go to prison if she chose to chest feed, right? So that is not how we really earn trust, with marginalized communities to participate in our health systems, right? And I think before I open up this question, I think that's something I always really reflect on is that, and I think this is so important for NACCHO's attendees to really, I think, challenge themselves and think a little bit about that. Medical mistrust isn't a problem to be solved. It's not a check on a checklist. We solve mistrust by earning trust. So Kenyon, you know, I know you have so much experience working in public health and fighting against state violence against people living with HIV and in other communities who are kind of targeted. What do you think is one thing, and then I'd love to hear everybody's thought on this. What do you think is one thing health systems can start just doing right now, today, to start earning trust and building that trust?
Yeah, I thank you. I'll try to, I might have 2 or 3 things, but but I think, you know, first to your point about, you know, mistrust is really important. And I think a lot of times people, especially when thinking about, you know, African Americans, you will hear, you know, references to the Tuskegee syphilis study or, you know, other Henrietta Lacks or other moments in history that create that mistrust. And those things are relevant and absolutely there. But there's study after study that actually shows the biggest contributor to people's mistrust of health systems is the experience that they or their families or people close to them have had within said health systems, right? So so trust is really, really important, not just in terms of the history, but actually what experiences people have right now. So one of the things I would say is I would really encourage, you know, health systems to really invest in the kind of training of both providers and then administrative staff and et cetera, in terms of, you know, how information is communicated about health issues. I'll just give a recent example. I'm a new resident of Sacramento, California. I've been on PrEP for like 11 years. I'm on DoxyPEP, whatever. I have tried providers in 2 different health systems, one of which is a place, an FQHC, that is sort of described as like the sort of LGBT friendly, you know, place to get care, whatever. And I have been referred to in both systems as a high risk homosexual. Right? like it's literally in my virtual data records. And I'm 51 and I'm about to fight these health systems about like that for the sake of everybody who uses them. But if I was, you know, me at 22, I would just simply stop going, right? I would not come back from my HIV test. I would not get results. I would stop going to those places, right? So I think it's like these kinds of things that people have to really, really think about, in addition to just the concerns about, you know, data sharing, or if you're, you know, are living with HIV and the kind of, you know, criminalization and surveillance that happens in those cases. Some of it boils down to just basic things like that. Like, you know, like I've been on PrEP for 11 years. I'm high risk for what? Like, you know, just like it doesn't make any logical sense, other than there's still, in this day and age, post gay marriage and everything else, a particular kind of hysteria around gay men who are actually having sex, right? Period. That's still embedded in how we think, in how our health systems think about notions of risk. So I would say that's, you know, kind of first is just real training and thinking about these things in health systems. The second thing I would say is, if you are in a state that still has some form of HIV criminalization, particularly on the books, I would you know, encourage people to actually start resisting, because the disease intervention specialists, or the people who you know, are testing folks, then have to put a form in front of people to say, like, the second you test positive, right, which people are going through a whole range of emotions then, but the thing after you find out you are positive, almost the next thing you have to do is sign a piece of paper saying that if you don't disclose my status to my sexual partners, I will be criminalized at whatever level happens in the state. And I think that we have to start fighting at that level. Like, just stop signing, just stop doing that, and obviously doing the work to advocate that providers aren't put in that position to do the work of the criminal justice system for something that shouldn't be criminalized at all.
So I'd love to hop in here with some humility, because, oh my gosh, following Kenyon is terrifying. But I did want to say, Amir, you know, I want to just be super clear that self-managed abortion is legal in New York, as it is in many states around the country. And the statistic that I shared, which, by the way, comes from Pregnancy Justice and If, When, How, if folks are looking to substantiate it, is about reporting behaviors during pregnancy as well as pregnancy outcomes of many stripes. It's not just self-managed. But I think, you know, picking up where Kenyon left off, In New York, our HIV criminalization law is actually significantly more draconian. It asks two things. Did you know your status and did you have sex? Nothing is exculpatory there. So really repealing laws like that feels really important. I want to name, as we're thinking about policy solutions, electronic health record segmentation as being a really important tool for building trust with providers. We have patients who come in who say, I'm really nervous. Maybe you traveled from a banned state and you're going back there, or that your primary care physician is a little squishy, and try to have conversations about confidentiality with their providers. And their providers have to say, well, the only tool I have is to get rid of your electronic health record, to not have any of your records shared. But by the way, if you turn it on at another provider, all of this is going to get swooped back in. So building the tools to allow the providers to actually respect patients' preferences around their privacy, and I shouldn't even say preferences, I should say needs around their privacy, feels extremely important. And I think, moving into the commercial space, right, we hear that with people right after the Dobbs decision, do I need to delete my period tracking app, right? So passing things like the New York Health Information Privacy Act will help lay a foundation for trust so that folks can continue to use these cutting edge technologies. If you are a healthcare provider, which I think is some of our audience, you also think looking at your own systems. What are you doing to be culturally competent yourself, right? Like some of us are white people working in this space, but also what are you doing to hire people who look like the communities that you are serving, or who speak the languages from the communities you're serving, or whatever that looks like, to make sure that you are meeting your community and your patients where they are, does a tremendous amount of work to build trust. And for the educators, I think I saw a statistic like nearly half of medical students who graduate in modern times believe misconceptions that Black people feel less pain than white people, and therefore are likely to give them fewer painkillers, right? That feeds right into the experiences that Kenyon's talking about that scares people away from coming. So it's not just about your data, but also about like, how are you breaking down these misconceptions? How are you hiring to reflect the community? And how are you building your own cultural competence, whatever your race and background?
Yeah, thanks so much, Ali. And Sarah, I'd love to turn it to you for the final word before we wrap up. I know Ali touched a little bit on the commercial side, the commercial surveillance side, but what are some like important just takeaways for attendees on like things we could do right now to earn trust?
Yes, I mean, I'm going to echo what Kenyon and Ali also said. Especially Kenyon's point that trust needs to be earned, and surveillance erodes trust, which pushes people away from care. And privacy is the antidote to surveillance. Data privacy protects against profiling, bias, and discrimination. It leads to safer and more secure systems. And when this happens, there's a better exchange of information and more full participation in health provisions. And this is an ancient concept. Hippocrates millennia ago baked privacy into the provisions of health services. And to that end, I would suggest a data minimization standard. That's what my report suggests. That's what EPIC works hard to promote. And this is a standard that limits the collection, processing, disclosure, and retention of personal information to that which is necessary to provide health services. And data minimization as a standard prevents inappropriate uses of health data, including law enforcement access and profiling and targeted advertising, and many of the other harms that we've been talking about for an hour. But yes, I would say that's definitely more of a legal standard and solution, but it does really protect data from some of the most harmful uses that we've talked about today.
Well, thank you so much, Sarah. And I really want to end by thanking all of our panelists who joined for this really important conversation. Thank you all. Thank you to NACCHO for your interest in engaging on these issues. We have links to the resources from CHLP and what our other panelists have been referencing that will be attached to this on-demand session. And we also have our contact information here. So please feel free to reach out to us if you have any additional questions, if you really want to talk about these policy, legal, or legislative solutions, or if you're looking to get some more grounded assessments on the experiences with navigating medical racism and surveillance and policing, we've got you covered. These are the right folks to reach out to. So thank you so much, NACCHO. Be well.